This is a short screencast about capped IVs. Capped IVs are IVs that are not connected to IV fluid, and they're used when we want to maintain IV access, but continuously running IV fluids are not necessary. You'll hear nurses calling them by different names. Saline locks, because we flush them with normal saline to keep them from clotting off. Sometimes we call them buff caps, and sometimes you'll hear nurses referring to them as hep locks because we used to flush them with a dilute heparin because we believed that that was necessary to keep them from clotting, but we now know that saline works just as well to flush them with. The capped IV is made up of different pieces. There is the cap or the port or the lock itself, and in this picture that's the white piece, and that screws onto extension tubing, and the extension tubing screws directly onto the cannula after it's placed in when we start the IV. And in this picture you can see the blue stat lock, which is the device that's clicks over the cannula, the hub of the cannula, and holds it securely in place so it doesn't move around. The reason, there's several reasons that the patient may have a saline lock-in. One is if they need medication administration via the IV, but they don't need fluids. For instance, a patient who is still getting antibiotics IV, but doesn't need the fluid, we may have a cap in. Sometimes it's there for emergency access. An example would be in labor and delivery. We usually put a saline lock in, not because the woman necessarily needs IV fluids, but because we know that hemorrhage is a real danger in labor and delivery and postpartum. And when it happens quickly, and we want to have the IV access there if we need it. It may be placed for diagnostic testing. For instance, a patient that's going to have some radiology done with contrast media, we use it just to be able to inject the contrast. And sometimes if a patient's had an IV in and they don't need the fluids anymore, the physician will just ask us to cap the IV, which means take the tubing out but leave the cap in, until they go home, just in case it needs to be used again. In this picture on the top, you can see the caps or the IV locks. There's a blue one and a white one. They're just two different types. And the picture on the bottom is a lock that's attached to the extension tubing, so it comes all in one piece. And those are just different ways that it comes. We also call them needleless access devices, and the reason is we used to have just rubber diaphragms on the cap, and we would need to access it with a needle, but now they're much more sophisticated, and we can screw the barrel of the syringe directly onto the cap without having to use needles. There's different types of caps. The first ones that were developed were called negative pressure devices, and in order to create a positive pressure in them to keep them from clotting, we would need to be continuously injecting the saline as we withdrew the syringe, and that was kind of a mess. So they developed positive pressure devices, which are what you see in this picture, and there's a mechanism inside the cap with a spring that keeps the positive pressure there without us needing to squirt fluid as we withdrew. The problem with the positive pressure devices is they found that with the mechanism on the inside, it would harbor bacteria, and those patients were at greater risk of getting an infection. So now they're developing neutral pressure devices that are the best of both worlds. You don't need to squirt coming out, and it has less of a device on the inside to cause problems with infection. So it's not important that you know the type of device your facility uses, whether it's negative, positive, or neutral pressure, but they are flushed a little differently. Some may need to stay clamped, others shouldn't be clamped, and so you just need to find out how your facility flushes the devices that they use and make sure that you're flushing it appropriately for that device. In order to maintain the access so that it doesn't clot off, it needs to be flushed on a routine basis, generally every 8 to 12 hours. And you need to know your facility's policy for how often it needs to be flushed and whether or not you should aspirate for placement in the vein before flushing and how much saline to flush with. And the aspirating to check for placement, I'll show you what I mean by that when I demonstrate flushing a central line. So just hold that thought. With a peripheral line, typical protocol would be to flush it with 5 mLs of saline, with a central line typically being flushed with 5 to 10 mLs of saline. So just know the policy of your facility. Make sure and flush slowly, so when you're injecting the saline, don't inject it real fast. It's isotonic, so it shouldn't sting the patient, but if you flush it too fast, it dilates the blood vessel very quickly, and that hurts, and your patient will let you know that it hurts. So go slowly. And the saline flushes are treated like medication because you are putting a fluid inside the patient's vein. And so they are listed on the MAR, and they need to be documented in the MAR, and you need to either scan the saline vial, or if you have a pre-filled saline syringe, you can scan the syringe, but it needs to be documented. Also, remember that it's believed that the most common portal of entry of bacteria into an IV is at the hub or the Y sites of IVs. And so it's very important that you scrub the hub every time you access it. And that means scrubbing the top, scrubbing the threads of the top, using good friction for a minimum of 10 seconds. Now, we know you'll see nurses not doing this very well, or even skipping it altogether, not cleaning it with alcohol. And this is inexcusable. It's lazy, and it's very dangerous to the patient. And there's no reason not to do what you're supposed to do by scrubbing the hub. Think about, would it be okay for a surgeon not to scrub his or her hands before going into surgery? No, because of the risk of infection. And the same thing with scrubbing the hub. So if you see bad habits, don't pick them up. Maintain your integrity and do the right thing, even though it takes 10 seconds of your time. If you're accessing a saline lock, you need to flush it both before and after you access it. So for instance, if you're hanging an IV antibiotic, before you attach the tubing, you would flush it with saline, then attach the tubing after scrubbing the hub, and running in your antibiotic, and then disconnecting the tubing, scrubbing it again, and flushing it. So we need to make sure and flush it before and after. And I wanted to talk about using saline versus heparin to flush with. Now with peripheral IVs, we don't use heparin anymore. We use just normal saline. But there are some central lines that still need to be flushed with heparin. Not all of them, but some of them. And so you will see vials of HepLock Flush, which is what's in the picture here up on the upper right corner with the light blue label. That's HepLock Flush, and you can see it has 10 units of heparin per ml of solution. The vial on the left is therapeutic heparin, the kind that we inject sub-Q to prevent clots in patients. And that comes 10,000 units of heparin per ml. So 10 units versus 10,000 units. Heplock flush is much more dilute. However, there have been many accidents where the nurse grabs the wrong vial because unfortunately they both have blue labels, and they flush with the therapeutic heparin, and that can kill your patient, especially if they're a tiny person, which we use heparin more often in children and babies because the cannulas are so small and we want to prevent clotting. So you have to be very careful. I also wanted to show you a picture of a pre-filled syringe, which is what you can see here. These are syringes that are pre-filled with 10 mLs of normal saline, usually, and they come wrapped in a cellophane package. They're out of the package here, and you'll see nurses with several of them in their pockets because we use them anytime we need to flush an IV. They come when they're manufactured and sterilized in the factory. The heat makes the rubber stopper stick to the inside of the barrel. So to prime it, you need to just gently push the barrel up to get that rubber unstuck. And they do have some air in them, so you need to make sure and push the air out so that you're not injecting air into your patient's IV. And that's all I have to say about saline locks. I'll demonstrate how to flush them in the lab. I will see you there.